All right, hi everyone. Thank you for coming to tonight's Grand Rounds with Dr. Rosanel. If anyone has any questions throughout the talk, please type them into the Q&A box at the bottom of your screens, and then we'll get to them at the end of the talk. Now I'd just like to introduce our speaker for tonight. Dr. Sarah Rosanel serves on the board of directors of JOWMA and practices full-time as a non-invasive cardiologist at Memorial Cardiac and Vascular Institute. She has leadership positions on multiple boards, a United Hatzalah Florida board member, a mentor in the Bal Harbor Chapter of the Solomon Leadership Program, a council member on the American College of Cardiology Florida Chapter, and nationally on the Women in Cardiology Leadership Council and Early Career Leadership, where she is one of 16 board members only. She was born in Casablanca, Morocco, grew up in Paris, France, and attended college and medical training in New York. She is also an associate professor of biology at Yeshiva University Stern College for Women, where she also serves as a mentor for women looking to pursue a career in medicine. And with that, take it away, Dr. Rosanel.
Hi, everyone. Thank you so much for coming tonight. Thank you very much to JOWMA for inviting me, and for you, Derek, for inviting me to come tonight and organizing that event and talking about cardiovascular disease, which is a topic I'm particularly fond of. So I'm going to share with you a few things tonight. So a little bit about me. I was actually born in Morocco, grew up partially in France. I came to New York when I was 17. I did most of my training there. I went to Yeshiva University, and then I went to the Technion in Israel, and then I came back to New York, and I did my internal medicine residency and fellowship at my United Medical Center. I just moved to Miami about a year ago. I'm practicing now full-time as a cardiologist. I'm actually on call this week. Hence the scrub, and I'm currently working at the Memorial Regional Hospital in Hollywood. That's a little bit about me, but Derek already said enough, so we're going to move on. So heart disease is actually the #1 killer in the world, and I'm going to talk more about that. I don't know if you know that, but half of the people who actually get to the hospital are the lucky ones. Half of them don't even make it to the hospital, and they die without even any warning signs. As you can see in this picture, this is what a myocardial infarctus, or an MI, looks like. So it's the leading cause of death in America for both men and women. And I'm going to elaborate a little bit more about the women's side, because it's something that we don't really speak about, and it's something that we haven't seen, or we haven't studied more in the past. But just so you know, heart disease can happen at any age. I cannot tell you how many young patients in their 20s, in their 30s, in their 40s actually have heart attacks. The risk does increase as you're aging, and we're going to speak about all the risk factors that are related to heart disease. But know that it also can happen at any age. Just so you know, for you to have a bit of numbers, roughly 1 in 4 deaths is actually coming from the heart. Something that's very important to know also is that heart disease can be prevented if we catch it early, and if you work on it together with your cardiologist, then you can decrease your chance of having the heart attack and the stents and the heart disease in your 50s or 60s or 70s. So one way to prevent the heart from quitting too early is to actually watch what you're eating. And we're going to speak about what are the things you can do to decrease your chances of getting a heart attack. So first, let's get some definition here. And by the way, remember you have a Q&A, a little box where you can ask as many questions as you want. And at the end, we're going to talk about each of them. So I'm going to say a lot of things, and something might be confusing for you. Something you may have read something in the news and you don't understand what it is. So just type it in, and I'm going to clarify all of that. So #1 is, what is a heart disease? What's a heart attack? So it's essentially a plaque that's going to build up inside the arteries. Eventually, over time, that plaque is going to rupture, creating a clot within the artery that's going to prevent the blood flowing inside that artery and causing a heart attack. So the heart is a muscle. It's supplied by multiple arteries around the heart, and it gives oxygen to the heart itself. If those arteries are blocked, there's no more oxygen going into the heart, and therefore the heart muscle cannot sustain anymore and will cause a heart attack. We're going to speak about what symptoms to look for a heart attack, and we're going to speak about the things that you can do to prevent it. So heart disease in women, I mean, just so you know, heart disease in general, like I mentioned, is a leading cause of death. But so far, there is very little attention that's been focused on heart disease in women compared to men. Just so you know, most of the studies that are done currently or in the past 50 years were really done on men. So if you study, for example, the medicine aspirin or statin, which are the very well-known medicine, usually 80% of the subjects were actually men. And very little is known and was known, at least until today, as of do women have a heart disease and a heart attack. So I'm going to speak about that as well. And I really emphasize that a lot in my patients that come to see me, because heart attack presents in many different ways. And oftentimes it is overlooked when it comes to a woman, because the usual symptoms of a heart attack is the chest pain that somebody may experience over the left side of the chest. Well, for women, it's going to be a bit different. They may or may not have that typical chest pain. They will have nausea with it, vomiting, stomach pain, back pain, feeling unwell. And most often than not, they will come to the emergency room and they will be dismissed. Somebody will tell them, oh, it's your period, or it's anxiety, or this is probably some GERD, which is acid reflux, but you're fine. And they won't even do an EKG. They won't think about doing an EKG on them, or they would not think about drawing blood work for the troponin, which is a specific enzyme that's elevated for a heart attack. Just because the symptoms come differently, and the way we have always thought of traditional heart disease has been with this typical chest pain. So I'm going to elaborate on that, and I'm going to really go into the details about what to look for, whether it's for men and women. So that's something I really wanted to emphasize. So those symptoms, by the way, that are listed in that slide can happen to both men and women, okay? But for women, it's a little bit more frequent than men. So first of all, like I mentioned, the typical chest pain, but you can also have this neck pain or the chest pain radiating to the jaw, radiating to the left shoulder, radiating to the upper back and upper belly discomfort. You or anybody can have a chest pain with a shortness of breath. I'm going to tell you a quick story. I had a patient recently who came in, a very young man in his 40s, healthy, fit. He told me, Doc, I don't know what's going on, but I'm really short of breath. Even walking my dog or walking to the mailbox, I'm out of breath. So funny enough, he was accompanied by his wife. And initially, when I did the first interview with him and he just came in to establish care, he was like, yeah, I feel okay, I'm good, I don't have symptoms, etc. Digging more into the history, then I was asking about the shortness of breath. And he told me, oh, it's probably because I'm out of shape. I've gained some weight in the past 6 months. It's probably nothing. But eventually, digging a little bit more into the story, you really understand that that person has been suffering from shortness of breath on minimal exertion and kind of putting symptoms, attributing it to something where it was actually, I sent him for a CTA, which is a coronary CAT scan, an angiography, and turned out that he had blocked arteries. And I subsequently sent him for an angiography where he had multiple stents placed in. So the shortness of breath on exertion is something that we call in cardiology angina equivalent. So equivalent meaning the same of or same as. So shortness of breath is something that's important, and I'm always looking for it when I'm interviewing my patients, whether in my office or whether in the hospital setting. So like I mentioned, the chest pain could also be pain in one or both arms. It can be accompanied by nausea and vomiting. Something also interesting is the sweating. Like suddenly my patient tells me, I'm having hot flashes, I'm not feeling well, I'm having this pain that I cannot describe, like a pressure, and I'm sweating. So something that's also very important, whether a patient is lightheaded or dizzy, that's a red flag in cardiology. That's something that we do an echo for, to look for valvular disease, and especially of the aorta. But that can also be a sign of a heart attack. Unusual fatigue. So some of my women patients come to me and they tell me, oh, I'm doing a lot of things. Obviously, I'm going to be fatigued. But again, you need to be a patient with some risk factors, and we're going to speak about who are the high-risk patients and have multiple symptoms of one or some of them. And then your cardiologist, or at least one of the neurocardiologists like me, we do a bunch of testing to assess your coronary artery risk factors and to assess and to risk stratify you into what category are you and what type of testing to do for you. There is an array of testing that we can do nowadays, thanks to the advances in technology and the advances in cardiology. One of the tests that we do commonly, back in the days, it really used to be the stress test, but honestly, with the coronary CTA, is essentially an angiography that we do through a CAT scan, and it delineates perfectly the arteries around the heart, and it can tell me as a cardiologist whether or not you have any blockages, and send you to an interventional cardiologist right away to get it fixed by your stent. So something that's important is know what type of testing you're getting, understand what type of testing you're getting. So many of my patients come to me and they tell me, Doc, I just had a bunch of blood work, I'm fine. I go on the computer, I go on my results tab, and I see that patient got a CBC, which is essentially testing for anemia, maybe a BMP, which is testing for the creatinine, and that's it. And the patient thinks that he got so many blood work, while actually nothing from a cardiology perspective was tested. So what do I mean by what type of blood work to get from a cardiology standpoint? And this affects people from any ages. I mean, I see patients from 18 and up, but what am I looking for in a blood test? I'm looking for the lipid profile to see whether or not you have high cholesterol already in your young years. Sometimes I'm also looking for something called an LP(a), which is a subdivision of a lipid profile to risk stratify you one more time and try to see if you have the gene for cholesterol disease from your parents. And that's going to be a big indication that you're at risk of developing a heart attack. I'm testing for the TSH, which is a thyroid, because a lot of heart disease are associated with thyroid disease. So I need to make sure that you don't have thyroid disease that's created confounding factor. I'm testing so lipid, TSH, CBC, CMP, and LP(a). So that's just from a blood work perspective. But also anybody who comes to me as a cardiologist gets an ID of who they are. And what for me, the first kind of ID that you're presenting to me is an EKG. So an EKG will give me a lot of indication about who you are from a rhythm perspective. And an EKG, by the way, when you go to the emergency room and you have this chest pain, is the first indicator whether or not you're having a heart attack. So I used to do a lot of semicals, the way we call them, which is when somebody is having a heart attack right away and they come to the emergency room. The emergency room does an EKG within minutes of the patient coming in. And they call me right away to look at the EKG and to tell them, yes, it's a heart attack. I'm going to open the cath lab right now. Or no, it's not a heart attack, and let's do some medication. So I used to do a lot of those. So an EKG is the number one kind of idea of who you are. Blood work, like I mentioned, in the office, I wouldn't do troponin because the troponin, which is this enzyme leaking from the heart, is actually an indication of somebody having an acute MI, which is an acute heart attack on the spot. And this, you see that in the emergency room. So like I mentioned, if a woman or a man is having any of those symptoms, in addition to risk factors, which I'm going to elaborate on that, you need to have an EKG done and troponin drawn, okay? So I've been speaking about risk factors. What does it mean? Age is an important one. So even though I mentioned that we can all get a heart attack, God forbid, in our 20s or in our 30s or in our 40s, as we grow older, we have an increased chance of developing a heart attack. It happens most often in the 50s, 60s, and up. Now, I always tell that to my patients. I tell them, I want to see young patients in your 20s and 30s, so that I do the appropriate testing for you. And then I follow you yearly to make sure you do not get a heart attack and a stent when you're in your 50s and your 60s. Because there's so much we can do together and work together to prevent you from getting the stents at a later age. So, like I mentioned, the older we get, the more at risk we are of getting a heart attack. Number 2, smoking. So smoking is a big no-no in cardiology. It's contraindicated for the heart. It constricts the vessel and creates heart attack over time. So every patient that comes to my office, there's a bunch of questions that I ask them. And one of them is, are you smoking? So funny story. Some of my patients tell me, smoking? Absolutely not, Dr. Rosanel. I would never smoke. Okay. Which brings me to my next question. Are you taking any marijuana? Whether it's smoking, vaping, ingestible. Oh, yeah. This, I do that daily, multiple times a day. So it's really interesting, the word smoking, at least here in America, the way it's being translated as something negative. And yet the marijuana, and I go on and on about the other things, then yeah, it's not a big deal. It's more in the culture. So smoking, marijuana, CBD, THC, cocaine, heroin, they're all associated with heart attacks. I cannot tell you how many times I've been called in the middle of the night to come assess the patient with a heart attack. Looking at that EKG and you see the acute finding of EMI, I go speak to the patient and the patient just did cocaine. So this is extremely important for you to know that it's related to heart disease and heart attack. And that's why try not to touch those things. Right. Next is high blood pressure. So again, coming to a cardiology office, number 1, you get an EKG. Number 2, you're going to get blood work, but cardiac blood work. Number 3, you're going to get your blood pressure checked. So that's extremely important because blood pressure or high blood pressure is actually a silent killer, meaning that you don't know you have high blood pressure until you test for it, because you can go on and on for years and years, remodel your heart completely and develop stroke and heart attack from very high blood pressure. So again, when I say high blood pressure, I mean over time, okay? I don't mean you're taking your blood pressure today, it's 160 and you're panicking. I have tons of patients that I follow for high blood pressure. It's something you have to be very patient about. We're going to try multiple things. First, we're going to do lifestyle modifications, and I will go on about that and explain to you what it is. Then we're going to, if that fails, we're going to do one medication. It will most likely fail. We'll do a second one and a third one until we get to the right regimen for you. So you have to be extremely patient with blood pressure medication. This is not a Tylenol and then you feel better. And this is not a problem if one time you have a high blood pressure. What is a problem if over time you always have high blood pressure and you leave it untreated, or you're going to tell yourself, I'm going to have garlic and that's going to be fine. That's going to treat my blood pressure. No, that's a problem. We're going to speak about that. All right, the next risk factor is high cholesterol. That is why every patient who walks through my door will get a cholesterol check, okay? Because all of those are risk factors associated with heart attack. Another risk factor is obesity, okay? Being overweight, having diabetes, insulin resistance is going to affect the blood vessels in your body and ultimately the blood vessels in your heart, around your heart. And those are extremely important risk factors to be aware of. And the more you know about something, the more you're going to be very careful about it. Like I mentioned, smoking, you're not going to do it. Blood pressure, you're going to have it checked periodically. Cholesterol, something. And with obesity and diabetes, You're either going to treat the diabetes if you have it, and you're going to change your diet. Okay, so more risk factors. Metabolic syndrome, which is the one I mentioned about with insulin resistance. Any patient who comes to my room, we always get that question asked, do you have any family history of a heart attack, a heart disease, a stroke? Because if you have somebody in your family that has had a heart attack in their lifetime, whether it's a father, a grandpa, an uncle, aunt, cousin, it means that you have the gene for it, and therefore I need to watch you and monitor you very carefully. The question I always ask as well is, are you exercising? So funny story, when I was in New York, no one was exercising and no one was actually answering me yes to that question. Now that I'm in Miami for the past year, I would say 95% of my patients exercise. And this is insane. I have seen over 2,000 patients since August at Memorial Regional Hospital, where I work currently. And almost all of them tell me, yes, doctor, I exercise. Oh, what do you do? I walk around, I do Pilates, I do yoga, I go to the gym, I swim. This is all wonderful. So kudos to the Miami people for that. However, I will say the cocaine and the vaping and the marijuana is much more prominent in Miami compared to New York. So when I ask my question, oftentimes my patient will answer me, what do you expect, Dr. Rosanel? This is Miami. So again, there's zero judgment. I always tell that to my patients. I'm not here to judge. I am here to educate you, and I'm here to hold your hand and to guide you toward the best cardiac health you can have, okay? So physical activity is important. Family history is important. Stress level, extremely important. Aren't we all stressed, okay? You have to be aware of that. And you have to know that it is a risk factor for heart disease. Of note, I don't know if you know, but there is a disease in cardiology called broken heart syndrome. The fancy word for it is called Takotsubo cardiomyopathy. And this is associated with an acute stress. Usually, it's oftentimes it's found in women more than men when the heart just becomes a balloon, gives up completely, and patients die from this acute MI, acute cardiomyopathy, acute stress episode. So that's something to also be aware of. Something else is a risk factor. It's called preeclampsia. So preeclampsia, for some of my pregnant women out there, or any woman who's been pregnant, they check your blood pressure, the OBGYN, very carefully, because if you have a disease of the placenta, that's going to be called preeclampsia. It's going to raise your blood pressure. And if you do, unfortunately, it means that you're at risk for heart disease. So I have tons of pregnant patients in my office, and they do have preeclampsia. They have high blood pressure in pregnancy, and I manage them as well, pre-pregnancy, during the pregnancy, and after the pregnancy. Other type of risk factor, and I have a lot of patients with lupus, with rheumatoid arthritis. So extremely important to know that those patients with autoimmune conditions are also my high-risk group. And I also should be very careful with them into testing them appropriately with the right testing to make sure they don't have any clots and they don't have any possibility of having a heart attack. So other less well-known risk factors that everyone should be aware of is liver disease, okay? So alcohol, by the way, talking about liver, is also contraindicated for the heart. So what do I mean by contraindicated? Meaning I don't want you to drink every night and to get drunk. The recommendation is 1 serving per setting. So for example, a glass of wine is not a glass of wine, and I emphasize that a lot to my patients. It's 4 ounces, okay? Or a shot of vodka is not a bottle of vodka, it's a shot. Or a beer is not a pack of beer, it's 1 beer. So we speak about that a lot with my patients as well. Once in a while is not a big deal, but I don't want you to drink every day, and I do not want you to binge drink, okay? That is associated with arrhythmia and heart attack. and liver disease. So liver disease is a risk factor. Another subgroup of patients that I see a lot in my clinic are the chronic kidney disease patients, which are the ones who need a kidney transplant. I have tons of patients like that in my work. So they're also a risk group, and therefore I treat them differently compared to the rest of the population with more aggressive testing. So like I mentioned, inflammatory disease like rheumatoid arthritis, all of that will double your risk of getting a heart attack. Like we spoke about the metabolic syndrome, which is like insulin resistant, diabetes, central obesity, okay? So that's all very important. Okay, so now that I've scared you enough and I've kind of told you what to look for a heart attack, now everybody's probably thinking, oh, I'm having a heart attack right now because I'm fatigued or because I'm tired, or I have shortness of breath right now. This is not what I'm talking about, and that's why it's important to see a cardiologist. But it's important to also mention to the cardiologist exactly what you're feeling. So many times I get patients that come to me and they attribute everything they have to something. So my woman patient will tell me, oh, I'm having pain over here somewhere, but it's because I lifted something, or it's because I'm lifting my kids, or it's because I'm very anxious, or it's because I ate something bad last night. So I always tell them, listen, you're here to tell me everything, and I'm just going to take all the information you're giving me and telling me, and based on those, I'm going to do the testing. So be very honest with your physician. Try to stay factual. Just tell them the facts. That way they know, what's going on for you, and that way they can filter the information and try to elaborate a diagnosis for you and a treatment plan for you. So how to prevent heart attack? Well, don't smoke or quit smoking. Tons of my patients come to me, they were smoking and they're trained really hard. I address that at every single visit, and they cut down from a pack a day to 5 cigarettes a day, then to 2. So we work very closely with them. I work very closely with my PCPs, which are the primary care physician and the internist. Of note, every one of us should have a cardiologist and a primary care physician. The primary care physician is key because they encompass everything in your body and they make sure you're reaching the right milestone and the right test that you need to do according to your age, like when to get a colonoscopy, when to get a mammography, etc. And the cardiologist, if you're young and healthy, I see you once a year. If you're not, then I'm going to see you every 2 months or every 2 weeks. You have high blood pressure and I need to tighten that up. So quit smoking, eat a healthy diet, and I'm going to speak about what's a healthy diet, exercise to maintain a healthy weight. You need to find ways to manage the stress, whether it's yoga or meditation or prayers or reading a book or sun tanning in the beach. I mean, no, sun tanning is a problem. Don't be in the sun too much. That's a different issue, but sun is a problem, not for the heart, but for other things. But in small doses, it's excellent. Okay, so avoid or limit alcohol. That's something important, and I spoke to you about that. Follow your treatment plan. You're going to have a cardiologist that you bond, that you connect with, that you trust, and you need to have a good, close, tight relationship with your physician. Because if you trust them, then you know that they only want what's best for you, and you follow the treatment plan. And you also have to manage the other health conditions, and that's why you have a PCP for that. So, lifestyle changes, lifestyle modification. I speak about it a lot. And one of the things that's important is nutrition and exercise, okay? We're going to speak about that a little bit more. Medication. So some medication are cardioprotectant, but I don't give it to all my patients. I only give them to a subset of patients that I've done a test for, and I found that they need to have aspirin or cholesterol medication. So if it was started by another physician and then the patient comes to me on aspirin or cholesterol medication, I would say, hold off, let's do a lipid profile, let's do an LPA, boom, now I'm going to get more information about the blood work. We're not done yet. I'm also going to do a calcium score. Now, some of you may or may not have heard what's the calcium score, but a calcium score is not a score. It's actually a CAT scan You go in the machine, out of the machine. It's very low radiation, very no contrast, and it gives me an indication whether you have inflammation that had already started in your coronary arteries, which are the arteries around the heart, and whether or not I should start you on aspirin and a statin. Some of my patients have this calcium score that's positive, and sometimes they have symptoms or they don't have symptoms, and I send them for further testing, like a CTA, which is a CAT scan to an angiography to a CAT scan, to get a closer look at those arteries around the heart. And again, if they're already starting to clog, then I will give you a medication to stop the progression of the disease, which means whatever you have, it is what it is. But I'm going to give you now aspirin and a statin, high intensity statin, like a Crestor, and both of them will decrease the progression of the disease, so that if you were supposed to have a heart attack, let's say in your 50s, now hopefully you have it in your 70s, 80s. But that's the whole point. We're trying to slow the progression of the disease, okay? That's why I keep on emphasizing that seeing young patients and doing the appropriate testing for them, you can know who's at risk and who's not. So like I said, heart attack can happen at any age. Unfortunately, we see it more in your younger years now, and waiting for the heart disease to happen is not the right thing to do. Like I mentioned in my first slide, half of the heart attacks are fatal, meaning they don't even get to the hospital. They don't get to come to me for me to look at that EKG and to say, yeah, it's a heart attack, let's open the cath lab. They don't even get to come to my office to say, hi, I have chest pain. So it's extremely, extremely important to know how serious that is to prevent that from happening to you. So like I mentioned earlier, what increases the risk of heart disease, we said the silent killer, high blood pressure, very, very important. So I'm going to speak more about the high blood pressure and how to prevent it. Something that's associated with first of all, the high blood pressure could be genetic. I have tons of patients are skinny, healthy, eat super healthy, exercise, you name it, and they have high blood pressure. So it's genetic, and I just have to treat them with medication. Other patients, they've developed high blood pressure due to poor eating habits. And what do I mean by poor eating habits? I mean by putting too much salt in your food. Too much sodium in your diet is actually not good. Even if you like it, if it tastes good for you, but it's not good for you, okay? So you cannot, you have to be very mindful about how much sodium, which is found in salt, you're ingesting daily. Because the recommendation from the American Heart Association, AHA, and the American College of Cardiology, ACC, is about 2,300 milligrams daily, which is found in everything. Sodium is found in cereal. Sodium is found in bread, in cheeses, in beets, in some vegetable, you name it. So you don't need necessarily to add sodium to your food. So be very mindful about that. Enjoying a potato chips bag once in a while is not a big deal, but not every day, and don't add sodium. By the way, sodium is found in those soup. You know, the soup where you add the water, that's very rich in sodium. It's found in soy sauce. So be very careful about my sushi eaters over here. And it's found naturally in some fish. All right, so then let's talk a little bit more about what's cholesterol, because I'm sure you've heard there's a good cholesterol and there's a bad cholesterol and everybody's confused. So to break it down in simple terms, there's a total cholesterol, which is a number. And some of my patients come to me, they say, oh, doc, I'm so worried. I looked at my cholesterol numbers and something was red on it. And it seems like my total cholesterol is blah, blah, blah. The number of the total cholesterol is meaningless to me. I am interested to know what's your LDL, which is a bad cholesterol. And I'm interested to know about what's your triglycerides. Those are the two bad cholesterol that I want to know the values. The HDL is a good cholesterol, it's protectant. Some of my patients who are salmon lovers, they have huge amounts of HDL, like in the hundreds, and very low LDL, very low triglycerides, and the total cholesterol number is high. Those are very healthy patients. They do not need cholesterol medication. They are fine. And I wish everybody had a cholesterol values like them. So it's important to know what you're checking and to know what you're looking for when we're speaking about cholesterol numbers. So like I mentioned, the cholesterol is bad because it can build up in the arteries in the wall of the arteries around the heart, and it can clog it, and eventually it can cause a plaque that ruptures and creates a blood clot and a heart attack. So like I mentioned, there is the LDL, which is a bad one. HDL is a good one. And the lipid profile is what I'm asking to get from every patient that comes to my door. There is no signs and no symptoms from high cholesterol either. So unless you come to me, you would not know, or me or any cardiologist, you would not know what's your lipid profile. Okay, so by the way, little break, put in your question box, okay? We're gonna speak about them. I've covered a lot of material, and I want you to ask questions and to participate in this talk, okay? So next point is added sugar, okay? So added sugar is not good. So a lot of time I also speak about caffeine intake, by the way. That's one of the questions I ask for my patients. And they said, no, I don't drink caffeine. So good, only caffeinated drink? No, not really. Do you drink Coke? Yes, I drink Coke. Okay, so Coke is caffeinated, okay? And it has lots of sugar. Then I ask them, diet on the regular Coke, if you have one every single day, unfortunately, you can be sure that in your 50s, you're going to develop diabetes. I've had very healthy, skinny, young, dynamic. He's actually a joker professionally. The joker is the one who does the horse races. And he comes to me, and one of the blood work that I forgot to mention earlier that I do for all my patients, not just the lipid and the CBC, CMP, TSH, but also the A1C. A1C, or hemoglobin A1C, is a value that's going to tell me what was your sugar level over the last 3 months. So it's not like, oh, doc, it was a holiday yesterday, or it was a party and I just had a cake. That's why my sugar is high today. No. We're talking about a value that tells me how you ate over the past 3 months, okay? And that patient, like I mentioned, this very athletic guy, comes to me with an A1C that was extremely high. Even though he was skinny and healthy, so to say, when we spoke about his eating habits, he was telling me he was having a Coke a day. So that's important to be very aware of how much sugar you're ingesting daily. Obviously, we would not eat cake every day. You would not have a sugary drink every day either. It's not healthy, which leads to diabetes. So diabetes, unfortunately, is also a disease that's not easily diagnosed, believe it or not. I had a lot of young patients in my practice that were seemingly healthy, and yet when I did the blood work, I diagnosed them with diabetes. Again, this young man had another young man, I have a lot of patients, had absolutely no symptoms. I was asking him, do you have any family history of diabetes or heart disease? No, I'm fine. He came to me because of palpitations, so we did a cardiac event monitor, which is a whole different talk. And then I did the blood work to kind of see who he was and risk stratify him. And I found an A1C of 10. A normal A1C is less than 5.7. From 5.7 to 6.4, that's what we call pre-diabetic, meaning you're on the range that you can tip over to the bad side or you can go back to the normal side. He was 9 when I diagnosed him. We go more into the history. Listen, are you thirsty always? Do you wake up in the middle of the night to pee? Yeah, of course I wake up in the middle of the night to pee. I've always done that. But it's because I drink a lot, because water is so healthy, so I drink a lot. I'm like, well, no, you're actually diabetic. Because you're diabetic, you're drinking a lot. Because you're drinking a lot and you're diabetic, you're peeing at night. We're not supposed to pee at night. If we're waking up in the middle of the night to pee, something is wrong. And he never mentioned it until I diagnosed him with diabetes. And if I hadn't done that blood work when he saw me, and he's very young, he's like 26, 28, this could have gone on until he would have been in a coma, diabetic coma, and a lot of time we diagnose patients like that, unfortunately. So it's extremely important to know what type of blood work you're getting and what are you getting tested for. Diabetes by the numbers. So unfortunately, patients who are diabetic are my very high risk patients. They have a 3-time increased risk of developing a heart attack. 30% of all the stents are actually patients with diabetes. They cause more than 300,000 heart attacks every year, and they have higher morbidity and mortality rates, unfortunately, and they have more chances of dying if they get a heart attack compared to the rest of the world. So my diabetic patients are a very specific group that I take care of, and to make sure that they don't have heart disease. Okay, so obesity, big problem with the society we live in, with the food that we eat. We go out to restaurants all the time, and in the restaurant they give you a 10 ounces steak, and that's normal, or even more sometimes. This is very dangerous, and we have to be hyper alert and very aware about that. So I will speak about the serving a little bit later, but just so you know, a normal serving of meat and chicken is about 3 to 4 ounces. So you're not allowed to have this whole steak that they're giving you. You're supposed to cut it in 3, have a third now. If you want another third a different day, or share with a friend. But if you go out to a restaurant a lot, that's very dangerous because you will increase your bad cholesterol and you will increase your chance of obesity. And exercising is not going to brush it off. It's not like I overate today, it's okay, tomorrow I'm going to do Pilates, or tomorrow I'm going to do a boot camp, and I'm going to take away the fat or take away the excess calories. In cardiology, it doesn't work this way. Whatever you ingest gets processed a certain way, and then it builds up in your arteries, and it's there, whether you've exercised tomorrow or not. So it's important to know your risk factors. It's important to have a healthy lifestyle from young years. So I always tell that to my patients. I said, whatever you invest when you're young, you get it back when you're in your 50s and 60s and 70s. So it's important from a young age to do the healthy living lifestyle. All right, so American Heart Association recommends, and something we speak about a lot, is that your diet and your lifestyle are your best weapon to fight cardiovascular disease. And we're going to speak about that a little bit more. Again, there is still limitation to diet and exercise, so I don't want you to think, I'm a vegetarian, I exercise 3 hours a day, my body mass index, which is my BMI, is like 20, so which is essentially perfect. Therefore, I'm protected and I don't have heart disease. Not enough. It's great that you do all of that. You still need to be tested because it can be genetic, and it doesn't matter how much you exercise and you eat well, you're still at risk of developing a heart disease. Okay, so exercising. So I get that question a lot. How much exercise should I do? The recommendation is each week you should aim to do at least 150 minutes of moderate physical activity. So if you do the math, if you do, let's say 30 minutes every day, that should do it, or 45 minutes, that's fine. But essentially, try to do fast walk if you can, to increase your heart rate a little bit. I'm not asking you to run a marathon, but I want some physical activity every single day to increase your heart rate. Okay, so that's what's important for me. If you don't feel like you're exercising, that's not the best. You need to walk a little bit faster. So that's something that's important. And regular physical activity is key. It's going to maintain your weight also and maintain your physical and cardiovascular fitness. Okay, so food. Food is a big topic. There's so many diets out there. It's important to eat from all food groups. Everything is important in moderation. You need to get all your nutrients from the protein, from the whole grain, from all the various food, basically. I am not a big fan of supplements when it comes to vitamins, etc. It doesn't get absorbed as much as the food. Let's say if you take a banana or an orange, vitamin C comes more from food than from a pill or from an additive. So it's important to eat from all food groups. Okay. Something that we spoke a lot in cardiology is called the DASH diet, which is dietary approach to stop hypertension. And again, it's related to the salt intake and the sodium intake that you take, because a lot of food is rich in sodium. You want the rule of thumb is you want to limit the saturated fat, the trans fat, the sodium, the red meat, the sweet, and sugar. So try to limit all of that. I'm not telling you to stop it completely, but have a very small amount of it instead of the big plate of something. Very important, don't smoke, don't vape, don't use any nicotine product, don't use any marijuana product, CBD, you name it, something about the CBD. So many of my patients told me, but it relaxes me, I feel so good with it, it's good for my mental health. I love that, good for you that it's good for your mental health. There's so many medications that are excellent for your mental health that are approved by the FDA, but approved from a cardiologist standpoint that will not cause you to have a heart attack. Please speak about it with your psychiatrist, with your PCP. Let's remove the stigma about mental disease. Mental disease is as bad as cardiac disease. The same way you would take a medicine for cholesterol, like a statin medication or an aspirin, and you're feeling good about yourself because you're protecting your heart. The same way you should take medicine for your mental health that will make you calmer, less anxious, less depressed, and that will have excellent effect on the heart. It's mind over body. So I love that, and I encourage my patient to take psychiatric medication. And also that's very tricky because it takes a long time. You have to be very patient for it to work, but I encourage my patient to do that, and I help them find the psychiatrist and the right PCP to do that. But don't use CBD. It's contraindicated for the heart and it causes a heart attack and arrhythmia and heart problems. Alcohol consumption. So how many times did I get that question? But doctor, didn't we say, and the French said that having a glass of wine every night keeps you alive for a very long life? Well, no, okay? The answer, and the studies have been done about it, is that alcohol has something called flavonoid in it. Flavonoid is found in a cup of grapes, in a cup of blueberries. So feel free to have a cup of blueberries every night or once every 2 days, instead of having a glass of wine. You'll get the benefit without having the risk, okay? So do not start drinking, do not binge drinking. And if you want to have an occasional glass of wine here and there, 100% fine, but try to limit yourself to 1 serving per setting. And let's say, I don't know, if you want to have fun twice a week and have a glass of wine or a glass of whatever, you know, it's okay, but that's important. So like I said, the flavonoid that's found in grape and blueberries. So that's something that's important to know. We don't recommend you to drink. So let's talk about caffeine, okay? Coffee, we all drink coffee, almost all of us. We love coffee sometimes. I really drink it because personally, because it keeps me awake. But we speak about that a lot with my patients. How much caffeine are you taking daily? And up to 1 to 2 coffee a day is not a problem. Unfortunately, there's some study that come up that multiple coffee a day could lead to arrhythmia and cause extra beats like PVCs and cause a problem in the heart rhythm. So that's something to always keep in mind and to be hyper alert about it. We spoke a little bit about the diet. So daily fruits, vegetables, healthy fat like olive oil, avocado, nuts, and seeds, that's wonderful. So just for you to know that it's okay to eat from everything, all the food groups, and not to say, okay, I'm not eating carbs, or I'm not eating bread, or I'm not eating meat. I'm not telling you to do that. Have a little bit per week, per serving, per setting. So usually the Mediterranean diet, which is very good in cardiology, it's daily intake of whole grain, using herbs and spice when cooking, legumes 3 times a week, fish twice a week, and try to have fatty fish like salmon, sardine, herring, and tuna. Like I mentioned, the salt, try to season it without salt. try to use other flavors. So a lot of my patients, I said, what? You're going to tell me to stop putting salt in my food? It's going to taste disgusting. Well, welcome to spices. So use onion, garlic, you name it. Tons of spices you can use. The other thing is, like I mentioned, don't have the salt. The other thing I didn't speak about, and that's important, is try to do homemade food. Homemade food, you control what you put in, you know exactly how much oil, salt, sugar is coming into your food versus eating the delicious food from outside in a restaurant. So once in a while, it's okay to go eat out, but try to eat at home as much as you can. And yes, it's annoying. Yes, it's a lot of work. Yes, we're very busy. But again, you don't want to spend that time when you're in your 60s, 70s, running from doctors to doctors and taking 17 pills. So invest now. And my last slide before we move on to quick Q&A, and I'm doing pretty good in timing, it's 8:54, is allow yourself an indulgence once in a while. Don't feel guilty about it. It feels good to take it and allow yourself to indulge once in a while. You know, a candy bar or potato chips here and there is not going to kill you. And but don't make it an excuse to give up on everything. All right. So with that, I'm going to give the floor to Aderet, who is going to lead this Q&A. Thank you so much for listening to me.
Thank you so much for speaking tonight. So I'll just read out the questions. First one, for healthy people with no obvious signs nor symptoms, at what age would it be indicated to make a preventative or first visit?
All right, so the first visit, I usually recommend it in your 20s already, because I'm going, like I said, I'm going to do a whole ID card on you. I have an EKG, blood pressure check, I have blood work done, and family history. I'm going to dig more into it. Once I know who you are and I see you stable, then I can space out the appointment. But in your 20s is definitely something that I would recommend.
All right, next question. I thought the use of aspirin for prevention has now been shown to be not useful.
So that's why I don't give it to everybody. So back then, it used to be that everyone who has diabetes, or everyone who has some family history, or everybody who feels like it should take aspirin every day. We don't do that nowadays, but we do testing. If I do the testing and I have a calcium score that's high, I'm going to put you on aspirin and a statin to prevent the progression of the disease. So I don't give it for all my patients like that randomly. I give it for a select group of patients.
Okay. Is my BMI impacting my risk factors?
Yes, absolutely. So BMI has to do with obesity and has to do with metabolic disease. And the BMI is a risk factor for developing heart attack. So it's something that's extremely important that I talk a lot about with my patients. And I monitor and I make sure that you try to lose weight. Again, it comes back to eating healthy, exercising, and I monitor you over time.
Okay. And regarding exercise, does it matter if I race walk 10 minutes 3 times a day or just 1 time for 30 minutes consecutively?
So it's preferable to do the 30 minutes consecutively because you're going to increase your heart rate and to make your muscles work more than just 10 minutes and then again another 10 minutes and then again 10 minutes. So it's also something that has to do with the exercise capacity and how you can handle stress, like physical stress, so to say.
And last question of the night. My father had a stroke and I see my family having strokes at older age. Is this genetic? How to prevent it?
Yes, stroke is genetic also. So we speak about that a lot in the visits with my patients. How to prevent it? Blood pressure control, extremely important. If somebody has stroke in the family, it means that there is some high blood pressure undiagnosed. So blood pressure control, which is not just in my office, but I also do something called blood pressure monitoring when my patient actually take the blood pressure once a day, write it down and bring it to me. So we do that multiple times a year to make sure that you don't have any blood pressure that's high. I also do something called a carotid Doppler, which is an ultrasound of the neck, to make sure there is no thickening of the arteries of the neck that could eventually lead to a stroke. I also do an echo, which is an ultrasound of the heart, to make sure there is no valvular abnormality, but also no structural abnormality that could lead you to have a stroke.
Okay, thank you so much for your talk tonight. It was an excellent lecture.
My pleasure. So I don't know if anybody has more questions now that we've opened the floor to questions, but you're welcome to ask. We'll stay here for another minute or two, and then we'll close up the lecture. Thank you for having me.
And thank you to everyone for joining us tonight.
And yes, the lecture was recorded. Right, Aderet? Is it going to be on YouTube?
Yes, I'm going to upload it to YouTube tonight, and you'll be able to listen to it there.
Somebody just asked a question, is the lecture recorded? Thank you very much, everybody. 9 o'clock, we did it on the clock.
All right, have a good night, everyone.
Bye-bye.